over billion people suffers from migraine around the world.
Let's talk about you. So you are a neurologist. Talk generally about your path to neurology. Why did you become a neurologist?
I actually was in love with human brain for as long as I can remember. And I grew up in a family where my dad and my brothers are neurologists. So I saw myself doing neurology and learning about brain. And I've been very happy about my career path, even nowadays when we know so much every day of new things about brain. It's unbelievable.
Yeah, it's one of those old kind of myths about neurology of back in the day. It's like, well, we know where the lesion is, but we can't do anything about it, right? But now it seems like more and more there are treatments for a lot of neurological disease processes, and hopefully more in the future as well.
Exactly.
So you are a headache specialist, if I remember correctly.
Yes.
Talk about the interest in headache medicine, why you went down that path.
I always think that every person, very beneficial for every person, create mission statement. And when I did choices in my life, I always would come back to my mission statement, which is create as much as I can pass for other people for less pain. And so headache field is so appealing for me. Every day, I'm so grateful to create less pain for as many people as possible. And I can do it by participation in research and be part of the process of development of new medications and new treatment modalities. And I can talk about it. I am surrounded by people who are on the same page with me. So it's really great to know your mission and create your goals and to move along with that. So headache medicine came very naturally for me.
Well, some of the students are saying you're a goddess because they suffer from migraines, and so they love their headache specialist doctors.
Oh, thank you. We do have big need for more headache specialists. Yeah. And we are very happy by this attention from students. So grateful for kind words and for being here. Thank you.
Are we seeing more prevalence of headaches or different types of headaches with the increased use of technology in our lives?
We do see some connection of lifestyle and headache. And it's not all about technology. There are ways to create very great lifestyle modifications and avoid increase in headache. Mm-hmm. So it's very important to take breaks. Yeah. And maybe just schedule your breaks, especially now when it's so appealing. If someone working from home with technology, just schedule breaks. Make sure you're not dehydrated. Make sure you don't forget to eat. Do little exercise. It goes long way.
Yeah. Talk about the training path to become a headache specialist. What does that look like?
So I went after medical school to neurology training. Mm-hmm. And after neurology training, we are welcoming people who are interested in fellowships. We're very happy to have fellowship in headache medicine, where you can learn all our new cool devices and new medications, and we have biologics now, and we still use what was used in the past and worked. So we're going to teach you all that and involve you in our wonderful community. and then you will be headache specialist.
just like that, like 1, 2, and you're done. I only wish it was that easy.
You know what? I just wanted to say it's very good to do what you love. And it's probably that's why for me it feels it's something which comes natural for you. It's easy to do every day. I love talking to multiple people and create together treatment plan, individual treatment plan for them. And it's exciting to see when people improve. So it's I don't think about it like about hard job. I think about it, oh, this is so exciting. I got to talk about all these new things.
That's good. When we talk to specialists, right, we'll have on a cardiothoracic surgeon who's doing heart transplants and lung transplants. A primary care doctor can't do those things. A primary care doctor can manage headaches. And a lot of the students watching this right now are likely to go into a primary care field. What is the threshold for taking care of a headache patient yourself versus sending to someone like yourself as a headache specialist?
I always very extremely grateful to primary care. I cannot emphasize enough and how grateful we are to have primary care on the team. I'm always happy to consult for primary care. I think threshold should be very low, and especially when it's disabling headache or disabling migraine is not just a headache. It's many more symptoms. We are always here for primary care and for our patients. I'm happy to consult. I am participating right now with American Headache Society in the program for education, which includes primary care and creates wonderful team of care for our patients. So I would say, when in doubt, first listen to the patient. When you have questions, reach out. We are here for you.
Now, you're an MD, PhD. Did you go to a dual degree medical program that gave you both degrees? Or did you do them separately?
Yeah, I went a little bit longer, and I did get my PhD already after medical school. And many of my dear friends in neurology community here, they did it during training, and I respect it a lot. It's a little bit more time, but it gives you this understanding of research and how to do it. So I always on the side of doing research, but it's not necessary to do things together. You can do it like I did a little bit after, or you can do it together if you're interested. For me, research, clinical research is on the very first place now, because I get my questions. What do we need? Where is this niche? What my patients need today? And we move forward in this direction, and it works great. Example could be inpatient treatment for headache. We see that if it's resistant, what can we do? And we do clinical research, for example, admitting people for headache treatment and figuring out what are the best ways to do that. So I'm really appreciative of idea to help you patients, but also move forward research. So you are part of the process. It's great.
Yeah, that's awesome. I want to dive into cases because students love cases. And then if we have time, hopefully we'll have some time for some Q&A at the end with the students. So let's go ahead. If you're ready, I'm going to share my screen here, and you can drive me and let me know when we want to move forward with slides. So I'll let you take it away.
My first slide, I'm very proud. I just got fellow AAM, so I put it in big letters. I love American Academy Neurology. Amazing resources for all students, medical and pre-medical students. And today, if you in the process of participating of this Neuroscience Day, it is day when Dr. Erb, who created popularization of our neurologic hammer, was born at his birthday today. So you can be in the drawing for this hammer.
Is it like Thor's hammer? Is it like that sort of cherished in the neurology world?
It's really cherished, and we're very proud. Just by use of our hammer, we can diagnose so much. And then prove that we were right with MRI.
All the students are saying congrats on that. I think it's one of those little known things that all of these medical associations, a lot of them have resources for pre-med students. And so I highly recommend, it's something that I've been adding to one of my podcast series that I do. Whichever specialist I have on, I make it a point to highlight the website for that specific society. So go check out the AAN. With my wife being a neurologist, we get all of the neurology magazines and journals and all of that fun stuff as well here at our house. So
amazing resources.
All right, so let's move on here. You have your little thank you here.
Thank you once again, and very appreciative of opportunity. It is extraordinary burden of headache. And this slide, I will not read it, but idea is still this year, global scores of disability, migraine is number 2 worldwide of years living with disability. 7 Americans will experience migraine attacks this year. Cluster headache is headache which has a reputation of being most awful pain person can experience. And big numbers here, 12 to 15% of population, over 1 billion people suffers from migraine around the world. And migraine affects women 3 times more than men, but cluster headache little bit more in men, like it can go undiagnosed in women, so we draw attention to this point. And we can move to next slide, which I'm saying because of this extraordinary burden of headache disease, we have extraordinary classification of headache disorder. It's amazing. I think it's the best. It's not only classification, it also will tell you treatment and how to diagnose it. It's 4 parts. First part, primary headache, such as migraine. Second part, if someone would have infection and headache, if someone would have stroke and headache, it can go to the part 2. Part 3 is facial pain, neuropathy, very famous one in neurology world, postherpetic trigeminal neuralgia. And part 4 is research and future studies. It's very nice to have part 4 and work on that and see how things moving from part 4 with research to other parts. It's living document. And we can go to next slide.
Well, a student asked, why are cluster headaches underdiagnosed in women? And I'll probably add an asterisk to that. Like a lot of things are underdiagnosed in women, just unfortunately for all things in women.
Because image which was in all textbooks, it would be men with cluster headache because it's more 3 to 1. So 3 times more often in men. So if woman comes in, we don't maybe think about it like number 1 diagnose, but now with drawing attention to that, we're doing much better job. So.
And I've seen a couple of times now students are talking about deep brain stimulation for cluster headaches. Is that a treatment for cluster headaches?
The interesting part about surgery for primary headaches, that we actually, because of progress in research, don't have to start with implanting things in the middle of the brain.
Yeah.
We can give people oxygen for cluster headache, and it works. We have new antibody approved by FDA, and it can work. And we do have all these amazing other medication and procedures and devices which we can try before big surgery. I witnessed time in the past when I was in training when we would have people debating big surgeries for migraine on the stage. Should we do it? Should we not? Should we implant neurostimulator inside the brain? Nowadays, we have 4 devices FDA approved for migraine, and we don't have to do neurosurgery. I got to tell my patients, if you don't like it, you can use it externally, put it in the box and send it back. So it's amazing.
Yeah, interesting. Okay. Thank you for that answer. All right. So I'm excited for cases. I know the students love these cases. So let's go ahead and roll into these.
Thank you. I thought I would start with one of difficult situation presented because of COVID-19 times. So we were on lockdown, and I couldn't offer our usual procedures as freely as we can. In the past, or now we restarted them. And I see pregnant patient, and migraine is acting out, so migraine attack, and it's telemedicine. And usually I would say, and we can go to next slide, I would say, okay, so this is excruciating pain, and next slide. Usually I would say, let's do Spino Palentine ganglion block or occipital nerve block, which is in-office procedure, but we both need to go there. And it's really helpful. It's much less harmful for baby during pregnancy, very good category for pregnancy, and used all the time in headache clinics all around. And what do we do? And we created great research, and we can go to next slide.
I just want to talk about this Spino Palentine ganglion block. It just as the picture shows, right? The Spino Palentine ganglion is all the way at the top of the nose, right? It's like getting a COVID test. Everyone knows what getting a COVID test is like, except just it has some anesthetic there, and you just stick it up there and hold it there, which doesn't sound very fun, but is supposedly very helpful.
So we do have these ganglions on the both sides of the nose. And it's a lot of parasympathetic nerves and maxillary nerves crosses by and other structures. So it's very helpful to put little bit lidocaine here, and it diffuses to the area. It's not painful when we do it in the office, should not be painful.
Yeah.
And lidocaine or other pain medication, numbing medication, makes it really nice for multiple people. Nothing 100% in headaches so far, but it could be extremely helpful. And what do we do? So we created this review of literature, this very helpful device, and we can take a look at next slide. It looks like nose spray, and it is nose spray. And it's amazing. So we figure out, if you sit up, you spray, then you lie down and you tilt to one side and stay like that for 5 minutes without strain to your neck. You get medication here. We have amazing review we did. We actually submitted to couple conferences and are waiting for results. Our abstracts on that, but a lot of good feedback. And the patients who cannot use other medication, and I gave example, it's like because of pregnancy, for example, They benefit in so many cases. And so I'm very proud of creativity, and we did it together with our UCSF team, and very proud to say that it worked for this case and for many others. And we can go to next.
Well, I'm excited about this. So something I don't talk about much is my daughter has a condition where she needs spinal taps every 4 months, and she had a post-LP headache, and she got a Spino Palentine ganglion block that helped her like in 10, 15 minutes with her headache. She was basically immobile with pain and then fine. She's 6 years old. So it was a struggle for her. But something like this, where a nasal spray potentially could help her, would be amazing, and we can just do it at home.
That's a wonderful example. Just made my day. It's excellent that it's helped.
Yeah. All right. So baby's born.
Baby born. We have so many more things to offer. So we still keep in mind that some medication can go to breast milk and get to baby like that. So we can, for example, use neuromodulation devices. And I put happy picture here. We can go to the next one. And then I just thought I would give little bit different case just to show that we do get to see different types of headache. And yes, bread and butter, probably we do see people who live with migraine, but we do see a lot of cases when we use our knowledge and creativity and can really help. So case number 2, 76 years old lady, new onset headache from few months ago. She has no nasal congestion. She has no other, we call them cranial autonomic symptoms. It's on both sides, and she has it pretty often, and it wakes her up from sleep in about 3 hours after she goes to bed, and it still lasts. And what is the treatment? And that's another amazing treatment here. So if we go to the next one.
I just want to clarify. So for students watching this, BL is bilateral, so both sides. And then cranial autonomic symptoms, is that what you said? Okay, CAS.
It's amazing. It's amazing that bilateral, yes, it's both-sided. And it is hypnic headache syndrome. It's alarm clock headache. So it's headache which recurs only when person goes to sleep, wakes person up. And according to this classification I mentioned, its criteria for that is more than 10 days a month for more than 3 months. And it lasts from 15 minutes to 4 hours after it wakes person up. So a lot of suffering can be involved. Wow. And again, no cranial autonomic symptoms, which means no nasal congestion, no eye running, no ear congestions, and so on. So pretty unusual headache, and we don't have other explanation for this one. And it usually starts for little bit older adults, like maybe after 50 years of age. And it's usually mild to moderate, but it disturbs sleep. So it could be very disturbing for person. And we can go to next one. And it's interesting that onset is not related to sleep stage. And program blocked my picture of coffee cup. So I put the nice coffee cup picture because this is the treatment. If person drinks strong coffee before going to bed, it's actually not going to keep them up. It's going to provide better sleep by creating nice treatment for this type of headache. And I know that many times when we have nice holiday celebration at university, someone would ask this question. And I know that last year I was sitting with our wonderful pediatric neurologist. We were so happy. We were like, yes, coffee. So coffee for hypnic headache.
Nice.
But other medication can work. Lithium, melatonin, and the medicine. And how do we know which one to use? So that is dream of headache neurologist, to know what works for whom, to have biomarkers, to have targeted therapy, get treatment right the first time without guessing. So we're moving in this direction.
Where do we see the future of CBD and other cannabis products for headache?
For headache, it's tricky because many things which work in the moment, even acetaminophen, if you use it too often, they can lead to medication overuse headache. I don't like use this term a lot because it's little bit like blaming person for taking this medication, which they need. So it's medication-driven headache. So we need to limit how much acute medication used in order to avoid this headache. And I think along these lines about cannabis. We don't know a lot about it yet. We need to learn more to recommend better. At this time, we would say limit acute medication, but use preventive medications. So that creates this nice idea of no suffering. And it's amazing that nowadays we have this completely different era of headache treatments when medications and devices can be used for acute and preventive. And we just love it because now if person has headache, we can say, here medication, just take it. So that's a big philosophy of headache field now. Create personalized treatment. Make sure that acute treatment is not driving headache forward. We avoid opioids for multiple reasons, and this is one of them.
I've always wanted my wife to get into a little bit more headache medicine as a neurologist for her, so that she can do Botox on patients and then bring home the extra and give me a little bit as I'm getting older. How good is Botox for headaches, and do you use it a lot in your clinic?
We use Botox for chronic migraine. Botox for chronic migraine, approved by FDA. It's 31 injections. So it goes, I do it all the time. And people with severe pain actually looking forward to the treatment because it provides, in many cases, it provides relief. And it goes all around the head and it goes here. So I don't know if anyone ever would agree to do this for cosmetic reasons.
Yeah. 31 injections, you said.
31 injections. Wow. It just emphasizing the level of pain and disability for someone to look forward for treatment. And Botox can help multiple people.
Good. Okay.
I just had to put this one as one of therapies which could be good for multiple reasons. I think this picture coming from Stanford publication, and this is dog named Tucker who provided telemedicine therapy, pet therapy for people during pandemic. I really enjoy this publication as we can move forward. And I placed few questions which did come up in the past during my meetings with pre-medical students. And what I wish I knew before going to medical school. I actually would like to say that I wish I knew how much more we can offer nowadays as opposed to when I was applying to medical school. Like, it would be so exciting for me when I applied to medical school to know how much more I can offer and help people. So I think it's excellent time for application for medical school. It's so many new things, and it's not going to stop. It's just going to progress. I do believe that. And we can go to next one. This is one of examples. My disclosure, I was PI, meaning principal investigator at UCSF Headache Center site for this device. It is device approved by FDA for cluster headache treatment and for migraine treatment. And I just put this picture to give idea that before, when we did surgery, we had to go through big process for that. Now it's external device, person just puts it here. And next slide, actually, if we move, I was very surprised to see that last month, I got message that device could be prescribed for breathing issues when someone waiting for COVID-19 test or has it. So it makes sense that its potential is there because vagal nerve goes up and treats headache, but it also goes down and can be helpful like that. I thought it's very fun fact. It's not something we do at Headache Clinic, but it's something I'm very proud to be part of this nice research and opportunity.
Wow, that's exciting.
And just discover you, Colin. I put picture of UCSF. I'm so grateful for my university. And it keeps me in love with wonders of human brain. So many things to discover. We still know very little % of the brain.
Yeah.
And next one. Balance. Many students asking, is it difficult to balance work life and home, family? And I believe that I'm better doctor because of love in my family. And my family has someone who can consult them on lifestyle modification. How great is that? And we can go to next. And this is example, like healthy eating plate recommended for headache prevention to eat frequently, but eat very healthy. And strict diets, they are not for everyone, but this is very balanced, healthy plate from Harvard website. It can be really good, like just this picture. And we can move forward to do mnemonic for success, like what we discuss about lifestyle and computer, sleep, exercise, eating, diary for people with headache to make sure that we know what was good thing to change, what maybe we should change back. Stress, we need strategy. Many people benefit from meditation, mindfulness, and seeds for success. So, and next one. What is most exciting at work today? I immediately thought that research works. Research gives us opportunities to create less pain and suffering, which I really think it is my individual mission for, and my goals align with that. So we can go to next one. And technology saving lives. We can do telemedicine. We have walking iPads. It's so much advancing technology that it's extremely exciting. And let me take some questions. I want to give opportunity to ask questions.
So I'm just going to clear everybody out here real quick. If you want to ask some questions, come on live with us, ask some questions. I'll stop sharing my screen and we can, if you want to ask questions, click on the little hand button and I'll bring a couple of you on to ask some questions. It'll take a second for them to jump on, but that's exciting. So talk about the bread and butter. You mentioned it briefly. It's a question that I like to ask because it seems like most physicians agree that you have to love the bread and butter stuff and tolerate it enough to enjoy your job. So what's bread and butter for you as a headache specialist?
I think that my regular clinic day would include work usually with someone who living with migraine. Mm. And we have most amazing community for that. So every day, my bread and butter involves working with people who have migraine, headache, or different types of symptoms which can come with migraine and figure out treatment plan together. And I love doing that. And we have very good opportunities for patients to participate in multiple programs, some of them created by patients, and we just helping, and I'm extremely proud of them. Example would be Miles for Migraine. We have our virtual events nowadays, but it's really great support. And awesome. I think we have someone join us.
Yeah, we have a bunch of people here. Tyler, you were the first one in the room. Go ahead and ask your question.
Hello, can y'all hear me?
Yep.
Okay, good deal. Nice to meet you, for starters, doctors. I just had a question. I had two questions. Mainly, it was just for clarification. One of them was, what was the difference between headaches and migraines, like physiologically? Sorry. And what are your thoughts on using LSD in order to treat cluster headaches or migraines?
I cannot hear.
Oh, you can hear him? So I'll repeat the question. Can you still hear me?
Yes, I can hear you. I wasn't sure.
So the first question was, what is the difference kind of physiologically between headaches and migraines? And then the second was, what are your thoughts on using LSD for cluster headaches, I believe was the headache.
So migraine is not just a headache. Migraine is disorder of multiple brain networks. So it makes it much more complex. It makes me always listen to my patients and believe them. If someone says, I have this very unusual visual change, could it be migraine? It could be, so we're going to discuss it. Someone can have weakness of arm and leg, like hemiplegic migraine, and we know 3 genes already for this one. And so because it's disorder of multiple brain networks, it makes my work extremely exciting, and it makes my work very interesting. So I basically love all neurology, and by being in headache field, I can participate in all of that. So that's been amazing. And I don't use LSD. I never was at the point when we would run out of approved treatment for a cluster headache and don't help someone enough. So it's, I know that it's been in some publications. I would say that please reach out to us. We have treatments with less side effects, and happy to share them. We have device and medication and procedures we can do.
Cool. Thanks, Tyler. Zach, let's go and bring you on and unmute yourself.
Hello. Can you hear me?
Yes, I can. Nina, can you hear him?
I cannot hear, and I'm so glad I asked. I thought that nobody can hear.
I can hear. So go ahead and Zach, and I'll relay it.
My question is, how would you treat patients who suffer from chronic migraines, but they also have a history of head trauma?
I saw this question. You asked it multiple times, and I didn't bring it up. So Nina, his question is patients with a history of head trauma, but are also presenting with migraines, right? It's very common, TBI causing headaches. How does that change treatment and prognosis and stuff? So history of TBI and migraines and or headaches.
Yes, we do see multiple cases, and it depends if someone has genetic predisposition, migraine biology, and superimpose head trauma. We might have to use multiple modalities of treatment and put a little bit more work right up front just to make sure that we're using all proper medications right then. If someone never had migraine and don't have family with migraine, no predisposition, and headache started within 7 days after head trauma, and according to our classification, it is post-traumatic headache, we still will do everything we can, but it will lead us in our prognosis, and it will help us to understand maybe how we can predict what's going to happen. There is wonderful conference I was part of. It was Sport Concussion Conference in 2020, and again at AAN. It's still there, and you can listen to amazing information. I learned some excellent points. Example would be head trauma can even change what happens in our stomach, like microbiome in stomach and gastrointestinal system. So we take it very seriously, and we really work with that.
Yeah, that's the subspecialty for my wife as a neurologist is sports neurology. So she sees TBI after TBI after TBI. So lots of treating headaches. Sean, why don't you pop on and ask your question?
Yeah, thank you for having me on here. I guess kind of what was spoke about there, as someone who played contact sports for 12 years, just Doc, what do you see, kind of a two-part, what do you see the future of contact sports such as football, hockey, lacrosse? And then do you see any of those cases yourself, and can you kind of talk to, what you see and what your common treatment methods are?
Good question. Nina, did you hear that one? Or no?
I didn't, but I had a feeling. I really want to know.
So Sean has a history of playing contact sports, and he's interested in kind of twofold, where you see potentially contact sports going because of the known risks in CTE and everything that we're learning about that. And do you get to see a lot of headache secondary to contact sports?
We do. So it's very big area of what we do, because multiple head traumas resulting in very resistant headache. So I would just say we have nowadays addressed this question with very nice guidelines when people can return back to play sports. So I would just follow recommendations. In the past, we did not have such a good guidance. It's still always work in progress, but I think it's very important to make sure that recovery is there, that person doesn't have multiple head trauma one after other one, and doesn't have good advice that stop for a little bit, recover, make sure you're ready to go back. And I think it is what we need to learn about contact sports more and more, how we can prevent neurologic changes and what would be the best schedule for people if you do have had trauma to return back, what would be rehabilitation, what would be exercise regimen. We know so much more. In the past, someone would just say, okay, now don't do any exercise if you hit your head. And we have beautiful rehabilitation techniques nowadays, including with technology. So I would say definitely things going better, but it's room for improvement.
Thanks, John.
Oh, thank you.
Joanna, come on, say hello.
Hi.
Hi there.
So my question was regarding coronavirus symptoms. I know some of them include loss of smell, loss of taste, and I was kind of curious as how that connects, how those symptoms are caused.
Oh, interesting. So a COVID question. Do you know the kind of the physiology behind why we lose our sense of smell and taste in COVID-19?
It's actually being studied all the time, right? And so what we investigate now, if these nerves which getting attacked by COVID-19, getting attacked first and suffering from that. So it's nerves which lets us to feel the sense of smell. Multiple neurologists stood up and they say, finally, these nerves are having so much attention, because in the past, we didn't always check it as we do now. And I did see publication from my university when one of people in internal medicine mentioned that it's actually very good advice to check, like screen check this nerve. And I completely agree. Nowadays, I see a lot of publication. Can we use it for therapeutics? Can it give us enough clue to get rid of the virus too? So I've seen some articles here and there about that, which make me even more proud of neurology. But we're looking into that, like, why this nerve?
Nina, question. I don't think you love neurology enough. I think we need a better ambassador on here for neurology. Olivia, hello. What's your question?
Hi, nice to meet you guys. Can you guys hear me? Doctor, can you hear me at all? I know we've been having some like audio issues.
I'll relay your question.
Sounds perfect. Okay, so when my brother was younger, I'll just start off with that. He had a lot of migraine issues. He would have them about 4 to 5 times a week, lasting hours. And doctors really didn't know what was causing the migraines or couldn't really figure out a way to alleviate the pain. And then suddenly he started going to the chiropractor, and with those spinal adjustments, the pain went away miraculously. And I was just curious if in the field, if you guys are exploring different types of alternative medicine and what that kind of looks like.
Nice. Good question. So Olivia's brother, unfortunately, had kind of unrelenting migraines several times a week for several hours at a time that weren't alleviated with any sort of therapeutics, but went to a chiropractor, and that seemed to help. So what's the kind of role of alternative medicine, alternative treatments for headaches and migraines?
I think it's very important to know exactly if we're treating migraine, or could it be a component from the neck pain? Could it be, we call it cervicogenic headache. Some people can have cervicogenic component. And if we don't address it, if we keep treating it as something it's not, then we don't succeed. So it's extremely important to take very good history from the patients and see if it's a lot of pain in the neck and other signs for addressing neck area. And I do think that things like behavioral therapies and meditation and things like biofeedback, and we know acupuncture can help relieve pain for some people. So we use them because many of those treatments, they have much less side effects. So I support all treatments which can help and less side effects. With chiropractor, if you ask any neurologist, we pause like that because it happens because when it's neck, we worry about spinal cord. And we love to see places where we do any manipulations. So, for example, at place where I work, I do collaborate a lot with neuroradiology, and they can see exactly where they go with devices. And when it's something blind without imaging, and someone tells, well, now I'm going to turn it really big time for you patient, I support other neurologist colleagues just to make sure you have very good specialists. I'm sure some chiropractic specialists extremely helpful and extremely well trained. So just make sure that you know the person, you discuss exactly what's going on. Some very good chiropractors, they do request imaging before they move it around. So just be a little bit on the careful side, but there are wonderful specialists out there, I'm sure. Yeah, consult your neurologist before you go.
Thanks, Olivia. Shane, let's bring you on. Hello. Oh, you're muted. There we go. Oh, one click. One click. There you go.
That?
There we go.
Okay, beautiful. Thank you.
Yeah.
So I had a question regarding like long-term prognosis for the majority of patients you treat, you know, migraines, headaches, whatever that ends up being. How many patients come in and, you know, after like, I don't know, 6 months of treatment or whatever, you know, the problem doesn't ever come back and they're fine, they live the rest of their life, versus how many patients will end up, you know, kind of managing their condition for significantly longer, either the rest of their lives or like up until, you know, they're elderly. You know, what's the long-term prognosis?
Yeah, good question. So long-term prognosis, when someone is coming in with headaches, with chronic migraines, and they finally get in to see you, a headache specialist, are you treating them for the rest of their life, helping them manage their headaches, or are you providing hopefully curative therapy and lifestyle changes so that they don't need you anymore?
So migraine is genetic neurologic disorder. Right now, we don't have way to take this gene out. We pose the goal to create life with functioning. I think my goal that my patients, they can do what they want in their life, with their work, with their family. And if they would happen to have migraine on some day, they have some tool, device, medication, something they can do, even if meditation helps. And I'm always here for them. I never would say that we're done with treatments. I always say, anytime you need me, please reach out and we will create plan according to situation. So I would usually support if people decide to do any, if someone decide to start a family, if someone decide to take job, which may be a little bit more stressful, and stress can be a trigger for migraine. We will create different treatment plan. And so we work together, but it's no indefinite in headache. Generally, things improving when we work together for multiple people. I love how my mentor, Dr. Godsby, put it. on last conference, he said, if you're smiling, you are a headache neurologist. Our patients usually improve.
Yes, that is definitely a good thing with headache. Thanks,
Thank
Shane.
you.
All right, last question of the night. Pearl, go ahead and unmute yourself. Hello there.
Hi, my original question was actually about cervicogenic headaches, but you kind of touched on that. So I was just interested in whether or not you could talk a little bit about the issue with lack of headache specialist neurologists. I know personally the wait list for most headache specialists that I called was over a year long in the Philadelphia area. So I think a lot of people kind of get stuck in a position where they're relying on their primary care doctor who might not have the level of training to really manage chronic severe migraines. And I think a lot of people end up using emergency departments for that too.
So the student is asking, why is there such a lack of headache specialists? She mentioned one reaching out for an appointment, and there was a year wait, and a lot of people going to emergency departments and other places for treatment. I have my guess, but I'll let you answer.
So that is such a nice question, and it's actually been point of advocacy this year when we went with group of wonderful advocates from patients and headache specialists from all around the country. It was Headache on the Hill in February. We went and we were talking exactly about it, about we need to train more headache specialists. Right now, for all this, we discuss how many millions people. We have 500, like little bit under 600 headache specialists in the United States. And we definitely want invite everyone, get interested in headache field and train more headache specialists. And our patients helping us to advocate for that, to create more treatment programs. We have Miles for Migraine. They actually, one of their wonderful missions is they support headache fellowships to create more headache neurologists. So we all on that together. And a lot of good things happening. And we have more trainees in headache field and more interest. I think that years ago, we didn't have much to offer, which is absolutely changed nowadays. So it's really appealing field, and we welcome interest. Like if you reach out, if you say, I want to do research, I want to do any sort of education about that, oh, we get so excited. I just recently got into couple wonderful students programs with UCSF. One is longitudinal PICES, beautiful program. And other one with students just coming to your clinics. And I'm so excited to share this knowledge and this like what we have nowadays. So please, yes, we always here for you.
Thank you. All right, Dr. Nina Riggins, thank you so much for sharing your time, your enthusiasm for headache medicine. You're definitely a great ambassador for the headache medicine world. So thank you for coming on and sharing your wisdom with all the students.
Thank you so much for having me. Questions were excellent. And I just really excited that I can be here and share it on Neuroscience Day and on any day. So Thank you so much.
Thank you, everyone, for coming. Have a great night. Stay healthy. Stay happy. Bye.
Thank you. Bye.